Okay, sorry guys, my mic wasn't working there for a second. Okay, well, welcome to a Talk Tools webinar. Today's presentation is Mastering Mastication with Talk Tools instructor Monica Purdy. We did pre-record her webinar. She recorded it last week, so it is up to date, just to prevent any technical issues with video. So we will be sharing that video with you. We did make a connection with her already. She is on standby, and we will have a live Q&A session with her at the end of the presentation. So just a quick show of hands, please confirm that yes, you can see me and hear me. There's a little hand icon on your webinar control panel, but I do see those hands going up. Thank you. If this is your first Talk Tools webinar, there's two important features that I'd like to point out. We have a questions tab and a handouts tab. Any questions that you have for me, technical questions, or for Monica, please submit that through the questions tab. And again, we will have a live Q&A. Monica will get on and do a Q&A with you at the end of the presentation. Additionally, her handouts can be found under the handouts tab. Finally, all participants will receive an email, a follow-up email by Monday to include a link to today's recording. Please keep in mind that all Talk Tools webinars have an expiration of 30 days. Also in the email is the certificate of completion, a copy of all the handouts, and the required course evaluation survey. So it is required to submit that survey to receive credit for this course. If you're seeking ASHA CEUs, please submit your ASHA number in that survey as well. Again, if you have any questions or if you haven't received that email by Monday, please feel free to contact us at continuingeducation@talktools.com. So I'll get that video started for you guys, and thank you again for joining us.
Hello, and welcome to Mastering Mastication, the Importance of Chewing. My name is Monica Purdy, and I am an instructor for Talk Tools, and I'm also a licensed speech and language pathologist. I have a practice in Indianapolis, on the south side of Indianapolis, and I mainly treat children in pediatrics between 0 to 21 years of age. This topic has kind of evolved out of teaching the level 1 course, the level 2 course for Talk Tools, and just understanding the importance of really teaching someone to chew. So this is going to give you some information about chewing, and then I'm going to talk to you about some strategies that I take and show you some videos of clients that I work with and how I kind of work on mastication. So I have to give you this by ASHA, just telling you that I don't get any financial relevance from any of the tools that Talk Tools sells. I do get an honorarium for speaking, and that's basically about it. So mastication. Mastication is the mechanical grinding of food into smaller pieces by the teeth. It is essentially a technical word for chewing. So you will hear those two words interchanged. Mastication breaks down food so that it can go through the esophagus to the stomach. Mastication is really important, and more important than you probably think, or definitely important to the fact that we should be looking at our kids and how they chew. And not only looking at them, but not just listening to, when you ask a parent typically, how does your child chew? Do they chew their food okay? And they say, oh yeah, they chew great. We need to, in our evaluations, also be looking at this to see, are they actually doing what they need to do? Is their tongue lateralizing? Are they chewing on their molars, or are they mashing with their tongue? Where is the food particles? Mastication is very important. It is so important that we often take it for granted. The ability for our clients to learn this skill and even to master the skill. This is something that we can't assume that a child is going to get, or a person is going to get. They need to be able to, we need to be able to teach them this. We need to be able to scaffold this down and teach them this particular process. Mastication is a sensory motor activity. It is aimed at the preparation of food for swallowing. It's a very complex and involved process. It involves facial muscles, elevator and suprahyoid muscles, and the tongue muscles. So when we look at mastication, it's the first process in digestion. It takes place in the oral cavity, obviously, and it has a close interaction with the sensory motor system. So for our clients that we see that have impaired sensory motor systems, so either they put too much food in their mouth because they can't feel it, or they have pieces still stuck in their mouth, and they end up just swallowing them because, again, they can't feel it. This is going to be something that we have to be very mindful of. Oftentimes, this sensory motor system, it's really important to look at the system, and it definitely will affect how a person chews. So we also need to look at their teeth, their orofacial muscles, their jaw muscles, their lip muscles, the tongue, and the production of the salivary glands and secretions. Mastication prepares the food for swallowing, and it helps get the digestive process started. So it makes it easier to absorb nutrients and helps promote feelings of fullness after we eat. We also could see the same issue with individuals whose sensory system is hyper or over responsive, meaning these are the clients that don't want to put anything in their mouth. They too will have issues with mastication simply because they haven't had the experience to utilize those muscles in a productive manner. When we eat food, the enzymes in our saliva, so there are two particular enzymes that we're referring to today, the lingual lipase and the salivary amylase. Both of these help break food in the oral cavity during mastication. They are made by the serous glands in the tongue and the back of the mouth. Lingual lipase works in the mouth and the stomach. It breaks medium and long chain triglycerides or fats into smaller bits. Salivary amylase is made and released by the salivary glands in the mouth, and it breaks down the breaks starch down into shorter chains of glucose molecules. So it works in the mouth, but once the salivary amylase reaches the stomach, the acid pH deactivates it. So even foods that are small enough to swallow without chewing should actually be chewed. And we can see that in the Journal of Medical Investigation in August 2006, found people who were fed via feeding tube did not digest their food as well as people who were able to chew and swallow their food. And they think that some of that is just due to the fact that when you actually start doing this chewing motion, you're activating these enzymes in your mouth that are going to help you with that digestive process. This is one of the reasons why, if you have a client who is being G-tube fed, we want to get them practicing this mastication. We want to get them using either mainly a non-food item to be making those movements while they're being fed through their G-tube. They always say you need to pair something oral, so eventually when you get the client off of the G-tube, that they will then understand that when I was doing something here, I was feeling something in my stomach and not just random, like a tube is making me feel full. So this is really important, and we'll talk more about that as well. Muscles of mastication are derived from, first, the brachial arch, that is the mandibular arch. Mastication is accomplished by voluntary muscles innervated by the motor branch of the fifth cranial nerve. We see this during the 5th and 6th week of gestation. One last thing I wanted to say, which I found is very important and really interesting, is that when a person does not chew their food completely, this affects that bad bacteria in their colon, which can lead to a multitude of digestive issues. So again, we need to look at when you have a client that has a buildup of bad bacteria or a leaky gut, we really need to be not only looking at food intolerances, but also how are they chewing their food? Are they able to break that food down so that they can get the most nutrients absorption from the food that they are eating? So chewing helps improve not only attention, and it helps increase cognition, and it reduces stress. One of the main reasons why this is the case is because our body, again, is a sensory system. And one of the sites of organizing and calming for our body is our temporomandibular joint. We get a lot of input through this joint. We get input through speaking, through eating, and when I say eating, I'm talking about a wide variety of foods. That gives us this input. You also will notice that when adults or children are trying to calm themselves or soothe themselves in situations where they're more anxious, or maybe when they're tired, you may see them biting their fingernails or chewing on pin caps or grinding their teeth or sucking their thumb. These are all ways that we get input to this temporomandibular joint. You will notice that when you are happy, what do you want to do? You want to call your friend on the phone, and you're, talking. You can talk for long periods of time. When you are, happy about something, you may say to your friend, hey, come on over and let's go have dinner. Or if you're sad about something, you may go get something to eat. All of these are ways in which you get input to that temporomandibular joint. So they really do, by working on mastication, you're able to teach that child to get that stimulation that they need to help regulate their system throughout the day. The masticatory muscles are a virtual part of the orofacial structure and are important both functionally and structurally. So chewing facilitates the eruption of teeth. We notice that as oral placement therapists, when we start teaching a child who has a diagnosis where they're going to have weak musculature, we start teaching them to chew very early on. You will see many oral placement therapists work with infants, and we start working on this chewing pattern. We start working on that, getting that reflex to maintain, so that then when the child is able to, as they get older, they're able to support chewing more difficult foods. We also notice that when we do this, one of the things that we need for our teeth to erupt is stimulation in our gums. So chewing facilitates the eruption of teeth. By about 15, 18 months, around the age of 2, a child will have coordinated diagonal rotary chew. So this is often balanced, it's unilateral rotary chew, and it maintains the symmetry of the face. So let's talk about the 3 primary muscles of mastication. The first one is the masseter muscle. And this is a muscle that is right on the side of the face. It connects from the zygomatic process down to the mandible. The temporalis muscle attaches to the top part of the mandible, and it is a fan-like shape that comes out in the head, out on the temporal side of the head. There are actually 3 different sections of that particular muscle that in a while I will teach you how to palpitate that muscle to see what you're looking for is any like trigger points. Are you looking for any muscle fibers that may be have like been tense or balled up together? Then you have the lateral pterygoid and the medial pterygoid. These muscles are what help the jaw open and close. So if we look at the first one, the masseter muscle, this is the strongest muscle. It has the most pressure of all the body's muscles. So the primary responsibility for this masseter muscle is closing the mouth. One of the things I thought that I would show you while we're doing this is that the masseter muscle, actually, when you palpitate this, you can, you would palpitate on the outside of the face here by having the client clench their teeth, okay? Then you'll feel that muscle engage. The other way in which you can palpitate it is to take your finger in and you're gonna go just toward the back of the cheek and you'll have the client clench, and then you can actually put your whole finger and thumb around that muscle, and you should feel that muscle engage. You can actually feel how thick and how strong that muscle is when you do that. The next muscle is the lateral pterygoid, and the primary in the medial pterygoid. The primary responsibility for both of these is closing the mouth. And when we look at these muscles, the literature actually says that it's really difficult to touch these muscles or to palpitate them. There are some people that believe that you can go inside and you can feel the muscle that is in front of the lateral pterygoid. I really don't, I'm not sure on, what I think about that. So I would just say that at this point, we need more information. The lateral pterygoid is the only muscle that helps open the mouth or open the jaw. It helps protract the mandible, and it creates that side-to-side motion of the jaw or closing the mouth. So again, with this particular muscle, it's really hard to palpitate it. Then we have the temporalis, and the primary responsibility of the temporalis muscle is to close the mouth, retract the mandible, and it helps with clenching the teeth. There are 3 different sections. There's the front, the middle, and the back section of the temporalis muscle. And when you are assessing this, it's really better to have the client be laying on their back when they're doing this. And then you're gonna feel, so if you have your mandible right here, you can feel where the heads of the mandible are. And you'll feel that when this muscle comes up, so it'll be right by your temporal bone, these muscle fibers go downward, so you can stroke them down to feel if there are any bumps or if there's any tension, or if it's a trigger point, like when you press that area, someone says, ow, that hurts. Then you're gonna know that that muscle is being activated too much, so that they're compensating for some way. Then when we get to the medial fibers, they're here. And again, they're kind of going down horizontal to the mandible, and we would be stroking again down. Now it's hard because I have glasses on. I would obviously take those off. And then the back part of the temporalis is actually above the ear, and it kind of comes over in a more horizontal kind of position. So the medial is more, it's like down and kind of angled. And then the temporalis is more horizontal above the ear. Oftentimes, again, we're feeling, are those the trigger points? Are those areas tender, or do you feel like a knot in them? Some other muscles that help with mastication are the digastric, the stylohyoid, the mylohyoid, and the geniohyoid. So ways in which you can kind of feel these muscles and assess them, again, by having the client lay down, and you can just go under the chin here, and you would go along the mandibular line, okay? So then you're gonna be you can kind of feel if there are any knots or tension, or if any of that is sore. Some people say to go in the mouth, under the tongue, and press down, but for some people that's really, really painful. So you can usually get what you need to do just by palpitating under the mandible. When we look at chewing, we know that chewing helps improve attention and cognition and reduce stress. But we also know that the mastication requires the temporomandibular joints in their jaw and it makes use of the lips and the tongue and the cheeks, that they all have to work together, and the palate and the salivary glands. This activity that we do when we're chewing, so using the jaw, the lips, the tongue, the cheeks, the salivary glands, this is usually automatic, and we take it for granted. It can be easily brought into a voluntary or conscious control. And that's really what we're trying to do with our clients, is we're trying to take something that is automatic and bring more cognition to the actual movement. In the article, Speech, Mastication, and Swallowing, Considerations in the Evaluation and Treatment of Dentofacial Deformities, by Jeffrey Postnick. He's a DMD and an MD, but he basically says that when food is introduced into the mouth, the lips help guide and control the intake. After the food is placed, the lips, they have to seal off so that you can get that intraoral pressure in the mouth. And that helps you then begin this swallowing process. So we know that the swallowing mechanism is a pressure chamber mechanism. When we're looking at mastication, we need to make sure that the lips are especially necessary when you're having a mixed texture, or when you are drinking as you're chewing. The tongue plays a major role in maneuvering the bolus so that you have sufficient chewing. The tongue typically initiates this process of breaking up the food by pressing the bolus against the hard palate, or moving it to the molars where it can be chewed into smaller, finer pieces. The tongue then pushes the food into the molar surface of the teeth, where it can effectively be crushed during the chewing stroke. And during the opening phase of the next chewing stroke, the tongue repositions and the partially crushed food again into the teeth for further breakdown. So one of the things that we really have to look at when we're looking at mastication is not only how the client chews or can they chew, but also we need to be looking at, does that tongue have independent movement from the jaw? And this is important because if the tongue is not able to lateralize and move the food to the molars, then that's going to affect the mastication process. If the lips are unable to come together, that's going to affect the swallowing process and the mastication process because you're not going to have that intraoral pressure that you need. So while the tongue is repositioning that food that has been displaced lingually, the buccinator muscle or your cheek muscle is compressing the food and has shifted into the vestibule back over the molars. So that cheek muscle helps keep that food on the molars with the tongue. They do this work together to help basically break the food particles down. Thinking back again to our clients, how many of them do not have adequate cheek muscles? Cheek muscles are needed for feeding and for speech. We know that feeding is a precursor to speech. You're using the same muscles in feeding that you use in speech. You may be using them differently, but you need to be using them. So oftentimes we see these clients that have these big suckle pads and they're 5 years of age, and we know when we watch them speak, they're not using their cheek muscles. We watch them eat and we know that they're unable to lateralize or dissociate their tongue from their jaw and keep the food on the side. When we watch them eat, we may see more of an up and down movement of the tongue and the jaw all working as one unit. And then what we'll often see is those particular clients, they know that they need to be chewing on their molars. So what do they do with their tongue? They dump it like this, right? So that's how they're getting that tongue. But dumping does not allow you to actually sweep and keep it in a cohesive bolus. Dumping just gets it to that spot, but it's still going to be spread out, and that's not going to help you with swallowing. The displaced food is continually being repositioned on the occlusal surface of the teeth until, the particles are small enough to be swallowed efficiently. The tongue is also used to separate the food particles that require more chewing. So it's really phenomenal. This is where that sensory system comes back into play, that when you're chewing something, your body knows that when it has the particles are small enough to swallow, you can often piecemeal that, right? So you would swallow some of it, and then the other bits that are not safe to swallow, your body knows from awareness that it needs to keep chewing them. Pretty amazing. There are therefore those particles that need to be continually chewed are placed back over the molars and are then continued to be masticated until they are safe enough for swallowing. This sort of process is essential to prevent choking or to prevent a client from swallowing large food particles. Oftentimes we see individuals that swallow this food whole. They often have limited gag reflex, or they're unaware that they've just swallowed their food. So I would always tell you that when you are doing an evaluation, it is really important to watch that client eat, to see what exactly are they doing with the food. Are they taking a bite and then swallowing it? After the eating process is complete, the tongue is used then to clean the teeth and to remove any food residue that has been trapped. So obviously, when we're assessing our client, if we notice that they don't have tongue lateralization or independent movement of the tongue, it's not like every time they chew, you're going to see the tongue go over to the side. They chew, the tongue helps keep it over there, they chew, and then it helps keep it over to the side. It's sporadic movement of that tongue, just helping work to keep it as a bolus. But if they're unable to do that, or we don't see lateralization, one of the things that we need to be looking for is tethered oral tissue. Is it because their frenulum is so restricted that they're unable to move that muscle? Or is it the fact that they're weak and they've never had the experience, or they don't know how? Sometimes it's just even a motor planning. They don't know how to lateralize that tongue. So now what I'd like to do is I would like to watch a video of the tongue, the lips, and the cheeks working together to keep the food between the grinding surfaces of the teeth. So you can see here, he's going to take a bite of pizza in the front. He's going to lateralize it over to the molars. That is a very high level skill. And then his tongue is helping to keep that food on the molars. As he chews, the food is then being broken down. You see those, that looks like, you know, I don't know, it looks like water or air. That's basically the salivary muscles, the enzymes coming in to connect with that saliva. When it gets into a cohesive bolus that it's safe, it goes back to the middle of the tongue, and then the client is able to swallow safely. Okay, and obviously all the way down to the stomach. Next, I want you to see, this is an up-close movement of the teeth when chewing. Again, this just demonstrates how the teeth are making that rotary chew, what that rotary chew actually looks like. So what they have done in this video, let me give you a little bit of background, is that they put some like a dye or kind of like a litmus paper on those teeth, so that when the upper molars and the lower molars meet, you'll actually be able to see where those teeth are touching and the contact that they're making. Okay, so there's the rotary right there. It's just a little bit of movement. Oftentimes people think, you know, when you think about a rotary chew, oftentimes they're thinking about kind of like a cow doing, you know, with a curd like this, and that's not a rotary chew. It's very minute movement of those molars. And the lips, the cheeks, and the tongue have to work together to keep the food between those grinding surfaces. But it's not like they're chewing up and down like this. When you get to that rotary chew, they're actually just grinding with the teeth together in that small rotary movement. Okay. Which really makes sense when you look at the when you look at the structure of the teeth and you look at, you know, how they fit together and the grooves and everything that they have, it's pretty amazing. So vertical chewing, the masseter muscle is the most important muscle, and the job of the masseter muscle is to elevate the mandible and close the mouth. The mastication process is influenced by the client's dentition that they have. Obviously, if you're talking about a client that has an open, you know, bite in the back, that's going to affect their mastication process. If you're talking about a client who has, you know, a cross bite, or a client who has, you know, a malocclusion, that's going to affect their mastication process. So a vertical chew is when the jaw moves up and down and the tongue follows with that up and down movement. A rotary chew is what we just saw in that previous video, where the jaw is in a circular motion, grinding the food. The tongue helps move side to side to manipulate the food, and it's usually the tip that is doing that. So next I want to show you a particular a video of just a person, a normal, typical chew and swallow. We do know that in mastication, there's a predominance of mandibular, rotary, alternative, drop shape movements. These jaw movements to the side where the food is located. In normal mastication, a client will switch between left and right side. This is, they keep doing this until the food is safe to swallow. Now, alternating mastication keeps the occlusal balance, meaning that it keeps you from getting one side of your teeth more ground down than another side. Oftentimes people ask, well, don't we all of us have a side that we tend to chew on or prefer? Yes, but it's not like you utilize that side and you never utilize the other side. If you were to see somebody who always went over to one side, that would be an issue. And some of the problems that could stem from that might be that they have weakness, or they might have, in the absence of a maxomandibular harmony, they might have a joint disorder, they might have muscle dysfunction, they may have a malocclusion, or they may have missing teeth on that side. So it is appropriate for you to go to one side, chew it, and then switch to another side, continue to chew, and then swallow. That's typically what we want to see. Food hardness is also something that we're going to discuss after we watch this. Okay, so very short, sweet. You can see that as that tongue, you know, got ready to swallow, it elevated and it propelled the food back. After they were finished chewing, it went back to the middle of the tongue, and then they were able to swallow. Okay. So he's chewing on the molars. You can see the tongue movement that he has there. You can kind of see the tip of the tongue there. Okay, and then that's him. This would be an example of atypical chewing pattern. So, okay, so she starts to put two pieces in both sides, but so you can see a little bit of tongue lateralization there, but then what happens? Okay, so I'll show you that again. You can, initially, when she is controlling it and is holding it over here, you see her tongue lateralize to that food source. But as soon as she lets go, that lateralization stops. The tongue goes back to the middle. You see this kind of up and down movement with her tongue, almost as if she's mashing it with her hard palate. And then you see, obviously, she has a forward tongue posture when she's swallowing. So there's some myofunctional stuff that's happening here as well. Okay, you see a little bit of that tongue lateralization right there. Then she just kind of munch, munch, and then swallow. Okay? All right. So the first piece of information that we have to look at when we are looking at mastication is the jaw. The jaw is the most important articulator. It's the most important anatomy function that we need to look at. It's the foundation for what allows our lips and our tongue to move independently when we are eating and when we are speaking. This oftentimes is the most neglected articulator. It oftentimes, therapists don't even, think about the jaw. They may see jaw sliding or jutting, or they may see limited jaw graded movement when someone is speaking, but they don't know what to do with that. There's a push for this to be taught at a graduate level, and it really does need to be, because the jaw is the most important articulator. And it's the first piece of information that an oral placement therapist looks at. So what are some of the reasons that individuals have difficulty? Well, the first one is jaw weakness. I don't really like using the term like strength when I'm talking about the jaw, because oftentimes when some people say, well, how much strength do you actually need to chew? How much strength do you actually need to speak? And I'm not talking about strength as in you're going to pick up a table with your jaw. I'm talking about more endurance. So when we notice that the jaw is weak, a person may have lack of endurance. They may not be able to, they frankly may not be able to compress their the jaw together in order to break the food apart. So they may have jaw weakness. And oftentimes when we have a client that has jaw weakness or difficulty in feeding, we're also going to see that same difficulty in speech. Not always, but I would say a good percentage of the time. So what that tells us is then we may see limited jaw graded movement when they're speaking. We may be seeing that they tend to prefer soft or easy to chew foods. One of the things that when we're doing an evaluation, when we start looking at the jaw and we're taking background history, is we need to be asking parents, so tell me, what the last 3 days, what were typical meals for breakfast, for lunch, and for dinner? I like to just go by, either that day, what did they have? Yesterday, what did they have? The day before, what did they have? Because then the parent isn't going to have time to really think. Like, when you ask somebody to keep a log, they tend to, especially if they know that you are looking for something, they may be introducing or giving foods that typically that child wouldn't be eating. So, and not always, but I think that if you can get it right then and there, then you're going to get a pretty good idea. Well, they have typically, what do they eat for lunch? Well, they eat, and they may name off hot dogs, chicken nuggets, macaroni and cheese, spaghetti. Okay, what do they typically eat for breakfast? Well, they have pancakes and oatmeal and you know, sausage, some of the things that you notice. I mean, sausage, you have to use a little bit more chewing, but depending on how refined it is, you may not have to do much chewing, as much chewing with that as you would if you were having like some sort of a melon or something a little bit more substantial, or toast. So oftentimes you'll see these patterns in how those children are eating just based on the jaw weakness. We also note that there may be difficulty with tongue from jaw dissociation. So again, when I'm looking at them eating, I'm looking to see, is that tongue lateralizing to the molar? Is it able to dissociate and keep that food on the molar? This is going to be really important for that mastication process. If they're unable to do that, I want to go a step further. Why are they unable to do that? And that's what I would be looking for in my eval. Is it because they have tethered oral tissue? Is it because they don't have the sensory feedback to understand that this is where I want their tongue to touch? Can they even make that movement, or is their tongue, the jaw is weak and the jaw needs to help the tongue? And that's often what we'll see, is that if the tongue or the lips are unable to do something, you will see a bigger muscle, such as the jaw, come in to help those things. Do they have OMDs? So do they have myofunctional disorder? Are they unable to, is their tongue unable to elevate to their palate, and they are unable to make you know, a suction with their palate to propel the food back? Are they using more forward tongue posture? Are they mouth breathing? Interesting enough, when you start looking at how a client is breathing, which, you know, in my opinion, should be one of the foundational things that you're looking at, you will notice that if you have somebody who is mouth breathing, you may see difficulty with their chewing. Why is that? Well, it could be because the jaw is weak. It could be so their jaw is in a lower position. It could be that they have enlarged tonsils or adenoids, which is also causing them to mouth breathe. And what we also notice with that is that those particular clients often have a preference or desire for softer, easy to swallow foods because of the space being limited in the back of their throat. When we start looking at breathing, we really start looking at, why are they not breathing from their nose? And, you know, oftentimes that's going to require a referral to an ENT. So when the food, when we start looking at this, we're going to start looking at what types of foods are we going to use, and what is the what's the difficulty in the way of chewing them. So some other issues that you know, could just be gross motor function, muscle tone, motor control. They could have developmental delays. Again, that sensory process. So this is, you know, to me, this is another huge area, because oftentimes you see sensory going along with all of those things listed above it. And frankly, their willingness or their desire to try new foods. Sometimes we know that if you've taken the level 1 class of oral placement therapy, we talk about when a child is unable to chew something appropriately, and let's say they have a bad experience. So the food gets stuck, or they start to choke, or, you know, God forbid somebody has to do the Heimlich maneuver on them. That's very traumatizing. And all it takes is one time for that client to then refuse any of the foods that either look like that, or any of the foods that, you know, or that particular food. So it could also be that they associate if they have GI issues, they may associate, when I eat this, my stomach doesn't feel good, you know? And for a lot of times, kids don't know that that's kind of what they're feeling. They can't, some of our kids can't even put that into words. So oftentimes we are looking to see, okay, do you have, what kind of reactions are you having? You know, are you crying after, you know, a couple hours after you eat this? Are you, you know, doubled over in pain? Are you having more reflux issues when you eat this particular type of food? You know, are you having diarrhea? Are you having, you know, flatulence? All of this, all of these are things that we would be looking at to see, perhaps, are there some GI issues? Do we need a referral to a GI specialist? When we start, something to think about, and I think this is important, is that as we, if we develop habits of mouth breathing, or we're unable to breathe from our nose, if we develop these habits of eating soft or easy to chew foods due to being a preference or lack of this muscle stability or strength, or lack of dissociation or lack of grating to chew these more difficult foods. So oftentimes you will see that somebody, perhaps they started mouth breathing because they had large tonsils, and then they get those tonsils out, and or there's adenoids out, and they're able to breathe from their nose, but this mouth breathing has now become a habit. The same with eating easy to chew foods. All of these are factors that could lead to difficulty with jaw, the face, the airway, and they can lead to serious health issues later in life. When we talk about, we do a whole webinar on breathing from the nose versus the mouth. And when we talk about that, we talk about the quality of life that someone has when they are breathing. So Dr. Kamar Haddad and Jean-Claude Lacroze of the theory of endobiogeny, they estimate that for most people, they need to be chewing, they chew between 5 and 10 times. Whereas many of the foods that people eat should be requiring them to chew 10 to 100 times for optimal absorption of nutrients. The optimal amount of mastication from their particular perspective is that you should be chewing anywhere between 20 to 40 times, assuming that you're having proper preparation of the food. So when we start looking at what are some typical chewing timelines, when we look at a 0 to 7 month old, you're going to have these suckling patterns. They may, you know, oftentimes now they're recommending that you start purees around 6 months of age. And so when they start doing that, you're usually doing purees via the spoon. Around 7 to 8 months of age, I would say more around 8 months, you might see that parents are starting to give their children meltables, or very soft, easy to chew foods, maybe the inner part of bread, or some really boiled like potato, something really easy. We will see that that child will then begin to start munching up and down, and then they start suckling. So they do this munching and then they suckle to swallow it back. By 8 to 9 months of age, soft solids, you know, can be mashed. So cooked carrots, cooked potatoes, and you'll notice that they're getting more of a vertical chew because they're starting to move that tongue independently from the jaw. Around a year of age, parents can often chop up or make little pieces of food for their child, and the children are starting to learn to do more vertical chewing. They're working on chewing on their molars. We know that as they continue to do this and to practice this, that a rotary chew starts to develop around 2 to 3 years of age. So some literature says like 15 to 18 months. I would say, 15 to 3 years is when this development is happening. The tongue skills develop to create and to keep that bolus. So I always look at it as like, the more you practice something, the more refined that movement gets and the more success you have at doing that. And then usually around 4 years of age, you'll be able to see a child close their mouth and rotary chew. Now, again, there are adults that you will watch eat that do not have closed mouth position and may not be doing a rotary chew. And that could be for a number of reasons. It could be because of their airway. It could be because they have tethered oral tissue that was never treated. There are many, many things. It could be that they have jaw weakness or this, they have the temporomandibular dysfunction. So lots of reasons can cause that. But a neurotypical child should be able to close their mouth and have that rotary chew around 4 years of age. So what are the things that we're looking for when we're looking at transitioning these foods into solids? So the very first thing is core abdominal stability. And this kind of brings up for me, I oftentimes will meet parents who are very interested in doing baby-led weaning. And one of the things that I think that you really have to be aware of is not that baby-led weaning is a bad thing or it shouldn't be done, but oftentimes, for me in particular, when I'm working with clients, they have other issues that are comorbid that could be influencing the success that they would have with baby-led weaning. So they may have, they may not have the core or abdominal stability. They may not have head control. They may not be mouthing toys, and they may not be interested in food. That would not be a client, and I am referring to one particular client that was unable to sit up and was 8 months of age, and the mom handed him a long piece of asparagus to chew on. The problem with that is that, yes, you want him to be doing the chewing motion. However, if a piece of that asparagus gets off in his mouth and he starts to choke, do you think then that that experience is going to be a pleasant experience for him, which feeding should be a pleasurable experience? Or do you think then he may refuse foods and that may have the opposite effect of what we want? I'm going to go with the latter. We know that usually a child's first solids are usually like a baby cereal or a baby food. Usually fruits and vegetables are pureed, whether you make your own or you buy them. Typically, we introduce new foods every 3 to 5 days because we need someone's sensory system to get accustomed, and their taste buds to get accustomed to these new flavors. There is a theory that you feed veggies before you do fruits because fruits are sweeter and children are going to like fruits more because breast milk is sweet and that's what their taste buds are used to. And then oftentimes between 8 and 10 months of age, we start getting into these soft solid foods or more cooked type foods that are easy to chew. So here you will see, this is just a little demonstration. You will see this little boy, okay? It's around, So he's, okay, so, okay, what I really wanted to see was that first little boy there. You can see that he's eating cooked broccoli. So cooked broccoli, if it's cooked right, will be very easy to chew, especially if they're, putting something on it, such as butter or oil or something to make it even easier to chew. But you don't have to use a lot of chewing skills to eat that broccoli. Now, you see him doing a little bit of food stuffing. For some infants or for some toddlers, that's appropriate because they're learning how much they can actually control in their mouth. You see that he's chewing on his side, and for the most part, his lips are pretty together when he's chewing. He's trying to get that higher level skill of keeping his lips together. So he's on that path to working those muscles in a dissociated way. Okay, so the next thing that I want to talk about is kind of, how do we get started? What can we do? Now, when we get started, we are going to be looking at, we're going to be gaining the case history. So when we're in any evaluation, you're always going to get case history. So again, when we're talking about mastication, I'm going to be asking things like, what does your child typically eat? Can you tell me the last 3 days and what they had for breakfast, what they had for lunch, what they had for dinner? I'm going to be looking at those foods to get an understanding of, are they easy to chew foods? I'm going to ask the parent, so how do you feel? Does your child have any difficulty with chewing? And oftentimes you'll hear parents say, oh no, they chew everything, or their bite is really strong because the parent has been bit. That's different than, remember, the endurance that we need to be able to chew a more difficult food and to be able to compress and break that food down. I'm going to be looking, do they have any developmental delays? What is their trunk and their core position? What is their tone in their body? Are they lower in tone in their overall body? That is going to affect how they can, maybe how they sit up, or I might be looking at that overall tone affecting their jaw musculature as well. What are their orofacial structures? So when I look at their jaw, do they have alignment? And we know that when we look for alignment, we're looking at the relationship between the back molars. What is their dentition? Do they have an underbite? Do they have a malocclusion? Do they have a crossbite? What is their tongue position? And when I look at tongue position, I'm looking at their tongue position at rest, and I'm also looking at their tongue position in function. So with mastication, in function of feeding. If their tongue position is low, then right there, that gives me, and their mouth is open, that's telling me that they have probably some underlying issues of jaw instability. And that's going to need to be addressed. That also could be triggering me to look for tethered oral tissue. Do they open mouth breathe? Is their palate high and narrow? So we know that for children that have restricted tethered oral tissue, their tongue then is not resting up on their palate when they're not speaking and just when they're at rest. This is really important because your tongue is a natural expander for your palate. So when you have somebody who has tethered oral tissue, their tongue cannot rest on the palate, and their palatal bones are going to keep coming together until they meet the resistance of the tongue. And if the tongue is low, and it could be in the mouth, or if the jaw is low and the tongue is forward, you're going to get a high narrow palate. I'm also going to look at this overall function. So I am going to watch them eat. I'm going to watch them eat purees. I'm going to watch them eat solids or semi-solids. And I'm going to watch them eat a variety of textures. So something that is meltable, something that is whatever the parent brings that might be difficult for them to chew. And that's always a very interesting thing when you ask the parent to bring you something that is chewy, something that is meltable, something that the parent considers challenging. What is it that they consider challenging? Is it a piece of bread? Is it a grape? You know, it gives you some insight into what might be happening with the jaw. I'm also going to be looking at environmental interactions and sensory regulation. How is their overall body response to input? If we're talking about somebody who is not regulated, who has sensory processing issues, then we might be looking at someone that we might not be able to go straight to their mouth and start putting something in their mouth. We might have to scaffold that process down and slowly start to work on desensitizing or gaining trust even to be able to put non-food items and then eventually food items in the mouth. So we're going to talk next about some strategies and some techniques. So how do we actually get this done? And when we look at our examination, one of the things that we can do in the examination process is we can palpitate that temporalis muscle. So this is a short video that talks about how to palpitate these particular muscles of mastication. And I will tell you, there are several YouTube videos just on different ways to do this. But the first is, one of the things that you want to do is you want to look at that temporalis muscle. So again, you can see that those fibers that I was talking about, how the ones in the front are going down toward that top ramus of the mandible. So she's doing it where she's just kind of, I'm going to take my glasses off, where she's just kind of touching. But it would be good if you were actually moving down like this. Now she's having her go into what we call a bulldog position, meaning that she's extending her jaw forward or jutting her jaw forward when she's doing that. I have not really seen that other than this video for the temporalis muscle. So when you're doing the temporalis, you're mainly just going here, then you're going to the middle where you're kind of coming inward, like in a diagonal position, and then the back part of the muscle is above the ears and it's more of a horizontal position, okay? When we're looking at the masseter muscle, and again, I don't think you need to have them go into that bulldog position for the temporalis muscle. So the masseter muscle, you can basically, when you have the client, you can feel this muscle when you have the client clench, okay? You can feel that muscle on the sides. And again, if you want, you could take your gloved hand and you could place your thumb and your forefinger inside the cheek right before the arch there, and you could have them clench and you can actually grab that muscle. So then you can feel it and you can see, you know, does one side feel bigger than the other side? I might be looking at that. I might be seeing, is there tenderness there when I do this? Okay. Now here's where she's going to, she's actually going to try to palpitate for that medial pterygoid. And again, there's some discrepancy on whether or not you can actually feel this. So you see her going kind of under the tongue like that. That again can be very painful for individuals. And this lateral pterygoid, this is often literature saying that it's very difficult to feel this particular muscle. Okay, what she's doing there is she's actually going inside. So one of the ways in which you can look at that or feel around where that lateral pterygoid is going to be is by going into taking your finger, let me get my glove back on here, is taking your finger and going up by your gum, and you're gonna feel like where your back molars are, that area right there, you'll feel that little like an indent there. So you'll feel the upper part of the ramus of the mandible, and you'll feel like a little groove area there. And oftentimes, you know, there's some people that say that that's kind of where you're palpitating that lateral pterygoid. Okay, so when I do this, I'm just looking at these things. I'm again asking, what does the child typically eat? Are there any oral habits? So are they a thumb sucker? Are they a teeth grinder? Those are often clues into either myofunctional disorders or jaw instability, or it could be overall sensory of the body. How many chews do they take before swallowing? So when I'm watching them eat, I'm looking to see, is their tongue lateralizing? Do they have an up and down movement? Do they have more of a rotary movement? Is there, are they just doing 2 bites when maybe it should have been like 10 bites? When we see them start to chew a piece of food, do the parents report that they chew it and then they spit it out? So sometimes parents will say, oh, they like chicken, but they never swallow it. They just spit it out. And oftentimes this is because, believe it or not, people know what they can and cannot handle. And children, regardless of diagnosis, are really good about this. They know what their bodies can and cannot do. And oftentimes we will see them start to, chew a piece of food because they like the flavor, but then they get fatigued and they know they can't swallow it. So then we'll see them, actually spit the food out. And we're looking to also see, like, what direction is that jaw moving? So is it moving up and down? Is it moving side to side? Is it over exaggerated when they're chewing? We know that in the elderly, there are different causes that impair mastication. So including the loss of teeth, inadequate secretion of saliva, oftentimes due to certain medications that the client might be on. They might have tongue issues, maybe they've had a glossectomy, the loss of muscle mass. We know that as we age, our muscles become weaker. And the same thing is true for when we're eating. Just like we need to continue to use those muscles, we need to continue to eat difficult foods. The consequence of that muscle loss is that it really decreases the biting force. There's also the pattern and the rhythm of mastication is altered with age. For instance, the number of chew cycles increases progressively with age to compensate for changes in food hardness, and the time needed for chewing cycle decreases. So modifications of this system, like for example, compensatory patterns, will be introduced when component parts are not in proper working order. So when the client is not able to chew something adequately, we're going to see them use a compensatory posture, compensatory model. Very interesting is that Dr. Sandra Kahn and Paul Urich, they wrote the book Jaws, and this is also this theory has also been presented and discussed by Dr. Mike Mew, MEW. They talk about that really our societies are changing, and that when we used to be able to eat more difficult foods, we were eating more difficult foods. Foods were not as processed. So perhaps our jaws are changing because the food that we eat is becoming more processed. Again, if this is a topic that interests you, please check out that book, Jaws, The Story of the Hidden Epidemic, again, by Sandra Kahn and Paul Urich. We might consider an enjoyable activity that involves the sense of taste, touch, and smell. So when we are looking at transitioning solid foods, what are some ways in which we are going to work on chewing? And these are just a list of things that you can look at or that you can do. Before we transition to solids, we want to make sure that that client, the muscles of mastication are ready to support the food that is going to be presented. So not only is the muscle stable, but again, does it have the endurance? And endurance is what allows us to speak from the beginning of the day to the end of the day. It also is what allows us to be able to chew our meal from the beginning of the meal to the end of the meal without having to take an hour to complete the meal. So within a manageable amount of time, you know, I would say, depending on the type of food that you're eating, you know, a meal could take you anywhere from 20 minutes to, 30 minutes. If you're talking and socializing, you might be, sitting at a table and eating for 45 minutes. I would say that's probably more rare in our society today. Oftentimes we can even see the epidemic of how fast-paced our society is getting and how much more processed the foods are. When you're trying to rush your child to this activity or this activity, you see parents giving them pouches and all kinds of easy to chew foods. So when we look at how we are going to teach someone to chew, there's a couple of different ways in which we can do this. The first is we can look at the chewing hierarchy. Now, Talk Tools has a chewing hierarchy that we use. This was developed by Sarah Rosenfeld Johnson. And in this particular chewing hierarchy, we are going to start with a gloved finger. So this is something that I can start with a client at a very young age. So, for example, with a client with Down syndrome, I might be starting with them doing this particular activity, at birth, okay? So a couple of days after they're born. I might be starting with a gloved finger using my pinky and stimulating that reflex. So going in on the molar ridge or where the molars are going to be and seeing, do they have the reflex? Can they munch? That's what they should do when I put my finger in their mouth. They should munch on it. So can I stimulate that munch? I'm going to see how many times they would be able to do that on each side. And you're going to feel how strong or not strong the jaw is by the pressure that's put on your finger. as they begin to increase that strength or endurance for chewing, I mean, my goal is for them to do 10 chews on each side at least 3 times. Then I might be able to add an infinite, okay? So now what I'm doing is I'm changing the texture and I'm changing the resistance of what I'm putting in the mouth, okay? I'm preparing that system to be able to handle different types of textures in the mouth and different types of food in the mouth. So again, I would turn bristle side up. I'm going in parallel to the molar or gum ridge, and I'm going to have that client practice that munch up and down chew. Once they're able to do that, and you're going to feel that with your finger, if you have a client that has teeth, you're not going to do glove finger or infinite. You're going to go to using a Sensi Wee Tip, which looks like this, and it goes on a Sensi tool. This tool also vibrates, okay? So it has a couple different speeds and a pulsing feature. But I will tell you that you need to be careful with vibration. I only use vibration when it is absolutely necessary, when that client needs that input to get a movement. Remember that vibration is a higher level tactile cue. So if we don't need vibration and it doesn't help increase the movement, we're not going to use it. The Sensi Wee Tip is, it's a flathead tip, so it's different than a Nook brush because it is not going to, it's not round, which isn't going to promote jaw sliding. We want that jaw to be moving in that vertical position up and down. So again, this is going to go on parallel to the molar or gum ridge, and we're going to have them chew on it. And we're going to be looking for that up and down movement. If the client started to chew, and then we saw their jaw start to slide or jut, then we would stop, and that would become our baseline. What's really nice about this Sensi tool is that Talk Tools has made them in different heights and different resistance and texture. So these are kind of correlated to their bite blocks. So here you have a bigger tool, and then you can go to a medium and then down to a smaller one. So oftentimes when a child is learning to use that jaw movement, they will be working on bigger jaw graded movements. And then as those skills increase, they will get down to a more refined motor or jaw graded movement. And that really helps a lot with speech. If you think about, you know, just how the client's jaw is grading in that up and down position, you may notice that they tend to talk like this, and they may only prefer eating really easy to chew foods where they don't have to do a lot of jaw graded movement, where they're just, or they tend to eat here in the front. The next thing is teaching them the bite tube hierarchy. So Talk Tools bite tube hierarchy is a way of working and teaching clients to chew without using food. The founder, Sarah Rosenfeld Johnson, often said that she would introduce food once the client was able to compress the red chew tube at least 2 times. Now, the reason that she put kind of that precursor to this particular activity or to chewing food is because she was seeing too many clients that were eating, that were being introduced to food, and their muscle wasn't ready for it. So then they were having bad experiences, and then you get into these situations where the client's refusing to eat or has had, you know, an emotional response. So when we teach clients, when we start with this, the chewing hierarchy starts with the red chew tube, and then you go to the yellow chew tube. The difference between the red and the yellow is the grade of chew. So you can see that this particular chew tube, the grade of chew is larger, okay? Again, when you're looking at clients that, from a developmental standpoint, that is a typical wide jaw excursion is what you see first before you see a more refined jaw graded movement, okay? However, if you have a client that speaks like this, the yellow is going to be easier for them than the red, okay? Just a note. Then we go into the purple grabber or the purple chewy and the green chewy. And the purple chewy is going to go in perpendicular along with, just like the red and the yellow, the purple, and then the green. These are different resistances. So we've actually graded the graded movement and the resistance that we're working on. When a client is able to chew this chewy tube, we should be transitioning these movements into function. So we might be having them chew and then go to doing a solid cubed piece of chicken, or having them chew and then going to a meltable. So we're transitioning this movement into function. We may only start doing that after they have completed at least 2 compressions. So if I put this in there and I see, and they're not even compressing it, I know right then that if they're not able to compress this, it's going to be really difficult for them to compress a food that I present to them. So I may want to work on this, and it usually doesn't take that long to work on getting them to compress this chew tube, and then introduce that semi-soft solid or that meltable food source, because that's only going to set their system up for success. And that's what we really want for our clients, is to have success. When they feel that they are successful at something, they will want to keep doing it, and they will want to keep practicing, and their skills will become better and better. We also can use Lori Overland's pre-feeding hierarchy, and this particular book by Lori Overland and Robin Merkel Walsh has all the pre-feeding exercises in it to help you. It's a sensory motor approach to feeding, and it's a really good book that you need to have in your library. So the pre-feeding chewing hierarchy would look something like this. This particular hierarchy was based off of Sarah's chewing hierarchy, but what Lori did was she took it a step further. So when you are having someone chew, the first level in both hierarchies is that you're going to present the chew tube on the back molar, and you're going to work on that client chewing up and down 10 times. Now, if they can only do 2 times, that's where you're going to stop. That becomes your baseline. And just like with any other exercise, when you go to the gym, you're going to work up to 10. So they would start here. The second step of level 2 of Lori's chewing hierarchy is that you're going to help start to work on that tongue tip pointing. Now, when you put something in your mouth, your tongue should automatically want to go to that source. Depending again on your sensory system, on your overall tone, this may be difficult for some clients. So we would initially start out in this position D, which is by your incisor, have them bite, and then move or roll the chew tube to the molar. So it would look like because what that's telling your tongue is something's here, something's here, something's here, something's here. So what are you working on? You're working on tongue dissociation from jaw. You're working on that lateral movement. Level 3 of Lori Overland's pre-feeding hierarchy is you're going to be using the chew tube, and you're going to be crossing midline with this. So you're going to be starting at D on the left, D on the right. And they're just going to be moving the tip of the tongue across that midline. Again, what do you need when you're chewing? You need for that tongue to be able to move and lateralize to both sides. And then the last step is where you're going to be practicing all of these to get a rotary chew. So you're going to start in the back and have them bite, go to D, go to middle, here, D on the left, and molar on the back. So that tongue should be following that chew tube around. And that's really how we're going to teach our motor plan for a rotary chew. Again, this information is in that pre-feeding sensory motor approach to feeding book, and detailed instructions are in there as well. When we look at ways in which we start to teach this mastication, you may be saying to yourself at this point that, well, my client won't even let me put a chewy in my mouth. My client won't even let me put my finger in their mouth. Sensory awareness is the first thing. It's one of the foundational things that we have to look at. We have to look at how can we help that client desensitize or regulate their body so that they can tolerate that stimulation. So if I have somebody who doesn't like me touching their face, I'm not going to start right at touching their face. I'm going to see where do they tolerate touch, and then can I work up to touching their face and then to going into their mouth. When we're looking at a child's skills, we need to be aware of what type of food we are choosing for them to practice with. Again, we want our clients to have success. So I'm not going to pick a carrot stick. If mom comes in and says that this is the challenging food for the client, I'm not going to start with that challenging food. I'm going to start with a food that is easy for the client to chew. And I'm going to then start looking at what are those muscles doing when they're chewing that easy food. Do we have lateralization of the tongue? Do we have graded movement of the jaw with an easy food? If you don't have those things, those are the foundational skills that you need to work on before you go to a harder or more difficult food. So one of the things that I do in therapy, which I have found a lot of success with, I did not create this. It actually came from a feeding clinic of one of my clients, and I have kind of modified it and continue to use this, is I like to use Tool. And it looks like this. When I use this instead of those mesh bags, I always am trying whatever I put in my mouth, in my client's mouth, I'm trying first in my mouth because I want to feel, what is that going to feel like? I have tried those mesh bags. They're meant more for oral play. They're meant for clients to get a piece of fruit in there and then just to be able to like suck the juice and just to play around with it in their mouth. They're not meant for chewing on the back molars. It's a very thick material, and it can, for clients that have sensory issues, it's too much, and it's too much input. So tulle is really thin, and it meshes really nicely. You can get it in different hole sizes, so you can get it where the holes are super tight together, or you can get it where the holes are a little bit bigger, that they're gonna allow some of the food to come through. But basically what I do is I will, cut a piece of this off, and when I start with an easy food, I will start by putting it inside this tool, and then I will hold it. So this is where I'm building that rapport with the client. And this is kind of what this video is going to show you. Are you ready to crush it? Yeah. Okay. Yes. Okay, so let me tell you a little bit about this guy. He is G-tube fed, and he eats some purees by mouth, but he's not eating any he's not eating any solids by mouth, and that obviously is one of our goals. He has had his esophagus stretched, which has helped tremendously. And this is kind of how we just start with desensitizing him. He's a very smart little boy, and he is very, his sensory system, he's very aware. So it's more over responsive. Here we go. 1, 2, 3, 4, 5. Yay! Good job! Wow, and I heard that. Did you hear it crunching? Did you hear that sound? It was like crush, crush, crush. Those were your teeth crunching it. Ready? 1, 2, 3, 4, 5. Yeah! Crush it. Okay, and I'm going to show you how you crunch it in just a minute, okay? I'll show you the video. So one of the things that we do, which you didn't get to see, is before I ever even go to the mouth, okay, I am going to have the client, and that actually what he had in that little thing was a mum or a little it was a really like a rice cake. It was super easy. It melted when saliva mixes with it. But you can see he's not really getting a ton of pieces off in his mouth. So he doesn't have to worry about where all those pieces are gonna be. And he's just working on, for him, the sound of that crunch. And the very first time that he did that, did you see his eyes when he heard that crunch? That was like, oh my gosh, that was definitely an over-responsive reaction to that. And he was a little unsure of this thing in his mouth, right? And I'm having him chew on his molars where I want him to chew. So initially, I would start by taking that tool and something in it, and I would just touch it on his fingers, okay? Now, this might be the area that you say, okay, let's count, and you want to be systematic. Anytime you're doing any kind of, new thing, or you're introducing something that is different, you want to be systematic in the way that you do it, because we want clients to know that there's an end to this. I'm not going to just keep touching your fingers with this or keep putting this in your mouth until I feel like I'm done. But that I want them to try. And if you try, that's awesome, right? It doesn't matter if you were successful when you tried. It just matters that you were able to try, because that is success. The more you try, the more success you will have. So we start out with touching the fingers. Then I will often touch the shoulder, okay? So now I'm getting closer to the mouth. I may touch on the cheek, okay? I may not. It just depends on the client. And that's why this really isn't a cookbook. It is more ideas for therapists. We may kiss it, okay? And we're always celebrating these little tiny steps, which seem like no big deal to you and I, are a huge deal to him. Before we ever got to crushing it with our teeth, I often will say, let's let the food stand on our teeth, okay? Which means that we're just gonna hold it on our teeth. So we're just gonna have it in our mouth and we're gonna count for a count of 5, okay? So this brings in a little bit of ABA into this situation, because if the client can't put it on his teeth and just hold it here, then that's what we're going to work up to. So we may only get to here and we're counting 1, 2, 3, 4, 5. Yay! We're gonna hold it on our teeth. 1, 2, 3, 4, 5. Yay! You held it on your teeth. That was awesome. Then we can do what he did in the video and we can have him crush it. Now, I'll tell you another technique that kids love is they love to see themselves being successful. So if I have somebody and it's really difficult for them, I will often say, do you want to take a video and then you can see yourself? So that's what he knows is kind of his reward, right? He wants to see himself on the camera. It's also a great opportunity. So if the parent isn't able to sit in on that session, I can then show the parent that particular video, and then he can also feel proud of demonstrating that and showing that to his parent as well. So it's for everybody. I always start with some sort of dissolvable or meltable food. These are just a few examples. Again, in Lori Overland's sensory and motor approach to feeding, she has more examples in there of different types of foods. We obviously have to be aware if a client has an allergy or a sensitivity that we're taking into account, you know, and finding the right food. The best thing to do is ask the parent to bring in the food, because the parent knows if the client is soy-free, dairy-free, gluten-free, you know, or is allergic to a certain spice, they'll know the foods that the client can eat. They just need you to guide them on, this is the type of food I'm looking for. And then they know probably what store it's at and where to go get it, or, you know, they can order it. So again, these would be, you know, difficult, these would be more meltable type foods or easy to chew foods. Now, another technique that I do, so I'm using, with all my clients, I'm also simultaneously doing the tool and this particular exercise, the slow feed, along with my chew tube hierarchy. So whether it's Lori Overland's pre-feeding or it's Sarah Rosenfeld Johnson's chewing hierarchy, they're doing these activities the same time that then they're being followed up with these functional activities. Because my goal is to drop this. I don't want a client who's chewing on this for the rest of his life. I want him to be able to eat functionally. So this particular activity is called a slow feed activity. And you can see that this particular client is doing a meltable. And what I'm telling him is, I want you to keep it on the side, okay? Okay, and what I'm doing, because he has been working on tongue lateralization, I'm telling him, keep it on the side, present it, right? So I'm giving him a tactile cue on his cheek to keep it over there, keep it over there. Now he's starting to cue himself, but I also may have to visually show him, push it with your tongue, okay? And just to kind of help them understand that that tongue is what helps it keep it on the side. So that becomes, you know, a great activity. Obviously, he's doing a great job. This is meltable. It's very easy to chew. You see me giving him some tactile cue on his head, because I want his head to stay in the neutral position. I don't want his head to come and help that tongue. I want his tongue to do the work and his jaw to do the work. I want him to learn to chew that or masticate that on his molars. Okay, this is another little guy. Now the video looks a little weird because I'm taping it. This was during teletherapy time because of the COVID-19. So you'll see that he is, his mom is introducing, I believe this is a tortilla chip, okay? This is a little boy who, when I first met him, he was 5 years old and he was eating purees. That's all he would eat, baby food purees. He does not have a G-tube, but he has this innate fear of food. And when I started probing and I was asking mom, like, well, you know, what happened? And she told me that when he was little, the speech therapist wanted to work on feeding with him, and she took a Fruit Loop and she put it in the middle of his tongue and he almost choked. And from that point on, this child refused to eat solid food. We are now up to the point where he is eating pancakes, sausage, eggs. He is eating soft tacos. So in the soft taco shell with meat and cheese. And he can vary that. It used to be that he could only eat soft tacos from Taco Bell. Now he will actually eat soft tacos at home, and he'll eat them with, like he'll eat a sausage soft taco. And that really, you know, that right now is his food repertoire, but that has really increased. And we're starting to work on introducing some pasta, some chicken, and just different foods that they eat at home. Sandwiches, so that when he goes to school, he, you know, used to have to take his baby food, and now he doesn't have to do that anymore. So ready, set, go. 1, yeah, 2, 3, big chews. Keep chewing. Big chews. I'm taking your video. Okay. Good job, buddy. Good job. Okay. So there you can see, this is just we're working very systematically. So I have told him how many times that I want him to chew it. You can see that he gets some pieces, and because he's unfamiliar with this, he gets a little like, oh my gosh, I don't really know what to do with this, and he goes to spit it out, and that's okay. I don't want to force him holding his mouth up or, you know, anything of that nature. I don't want to force him to do that. I want him to do it and have success. So the next time when we go to try this, I want him to know, okay, this is what it feels like. I could have made this a little bit easier for him by putting it in the tool. Again, you can see that mom, I'm kind of working through the video, and mom is, you know, my hands at this point, which is good because it's helping her understand what to do, and it's also helping the client know that it's not just something that he does with me, but that he does with his parents as well. So he's making tremendous gains, and because we are working in a slow, systematic order, and he's, you know, already completed chew tubes, so I know he has the strength to do more difficult foods. We're just going to work on the endurance. So this is, sometimes when you get to a point, you need to increase the difficulty. So you could do this a couple of different ways. One of the ways in which you can increase difficulty is by going to a more difficult food. So instead of having something meltable in here, I would have maybe like something more difficult, like chicken or steak or a vegetable, something that requires more chewing. Again, I like to start with the tool because for those systems that are over responsive, I don't want them to have to, I just want them to work on the motion or the motor plan and the taste and the feel of it. I don't want them to have to work on trying to manage it in their mouth. As their skill increases and you see their overall body reaction it's not any big deal for them to have it in the tool, then I will take it out of the tool and I will hold it there so that then they can start working on learning how to manage that in their mouth. Another way in which you can work on these things is gum chewing. I love gum chewing. Gum chewing is a great activity because it is not only regulating for someone, but it also, depending upon the gum and the size of the gum and the resistance of the gum, is a great jaw grating activity. It also works on mixed textures. So with this little guy, this is the first time that he's ever chewed gum. And again, I'm presenting it in the, okay, so he's a little unsure of it. You can see that. Okay. Okay. And it's really hard. So this is bazooka. It's half a piece of bazooka. Okay, so I'm trying, so you can see he's tasting the taste of it, right? And it's super, super hard. I'm showing him, he doesn't know how to chew gum independently. So I'm not just gonna give him a piece of gum. I am going to teach him how to chew it. So every time I'm gonna be taking that out, he's gonna be giving it to me. And you can see he tried to take it out there and give it to me, right? So, and I'm telling him, now I'm gonna ball it back up because this is what eventually he's gonna do with it in his mouth, is keep it in a ball. And it's getting softer the more that he's chewing it. It's also getting juicier. So in Talk Tools Level 1 class, we talk more about gum chewing, and we actually teach you how to teach a client to gum chew. But I just wanted to make you aware that that is definitely a way in which you can increase the difficulty of a task. You just have to note that if parents don't want them using like a sugar gum, if you use like a sugar-free gum, that's totally fine, but you're gonna need more pieces of that so that the resistance is more, and that they're actually having to work to chew it. So instead of like a half a piece of bazooka, you might using 5 pieces of a sugar-free gum, okay? Because the texture is so different when you start chewing it. So what we're going to be looking for is we're just going to be, again, task analyzing. This is a small checklist that just kind of, you know, jogs your memory when you're talking to the families. You can add to this checklist. You know, one of the things that I would probably add to this is just what are the types of foods that the client is eating. And I think that that would be a really good thing to do. You could also add how many times, you know, red, yellow, purple, and green chewies, how did they do on those chew tubes? Were they able to compress them? Was their jaw sliding? Was it able to maintain? And, you know, really, that's pretty much the way that I teach mastication. It's not very complicated. It's very simple. And what I find, the main thing is that your clients have to have success. You have to start at where they are at and work on either desensitizing or helping them regulate their bodies so that they can tolerate that stimulation and they can tolerate those different flavors and those different textures in their mouth. So if you do that and if they have success, they will want to keep trying and they will be more apt or more likely to want to try different foods. So if you have any questions, I would love to take those now.
All right. Hi, Monica. Can you hear me?
Yes, I can.
Okay, I'm going to stop sharing that. Okay. So we do have a question. I saw it came in earlier. Let me get that back up. It's from Stacy. She said, can you explain how large tonsils would impact on chewing? I have a 13-month-old on my caseload with grade 3 to 4 tonsils who has front to back tongue movement and up and down chew. I wasn't able to access for TOTS due to COVID restrictions. It was an online consult.
Okay. So yeah, when you're looking, tonsils can impact the swallow aspect of the pharyngeal swallow, just because the tonsils are, if they're really large in that manner, it may be impacting what that client is choosing to eat. So if they're choosing to eat very soft or easy to dissolve type of foods, that can impact how they're going to, swallow, because it's going to be easier for them to swallow because the tonsil tissue is so large. However, if that continues and they always choose those foods that are easy to chew, you might see that then they end up having some weakness, or they might end up becoming very, having foods that they only prefer. It also just depends on where they are with the, like where their sensory system is. Any kind of time that somebody is going to have difficulty, those sensory things can then become a habit or a behavior, so to speak. So, I guess I would be more inclined because of sleep, because of breathing, also because of eating, to have those tonsils looked at. That would be my recommendation, because it can impact feeding, just having the client be more selective, also not choosing to eat more difficult foods.
Thank you, Monica. We did get a question in from Sandra. She was asking about handouts. Yes, we do have handouts. You can find it under the handouts tab. Additionally, we'll sending a follow-up email that will include copies of the handouts as well. And then from Eric, they asked, because of definition problems, would I be able to place boluses on premolars? Would the child be able to adequately crush the food?
Oh, because of dentition problems? Okay, so that's one of the reasons. It depends on what type of dentition issues that you have. If you're talking about like a malocclusion, or if there's cavities, any of those things, yes, they will impact that. But oftentimes, if there is a dentition issue such as a crossbite, or that puts that client's jaw in a compensatory strategy already, so they're probably going to be looking to help make contact with those teeth. That's one of the reasons why sometimes I go to using tool, because if they don't have a strong bite yet, I don't want there to be the opportunity to have all these pieces, or to have larger pieces in the oral cavity that could then cause some sort of a a sensory, you know, freak out or like, I can't handle the food. So by putting it in the tool, then you can actually kind of see, because you have control on what those teeth are doing. If there is an open bite back there, obviously that's going to make it harder. And then you might be looking at compensatory ways for them to chew until they can get that corrected.
Thank you, Monica. And from Celeste, where on YouTube are the videos you shared?
The videos that were embedded in the presentation.
I assume that's what she means. We can always get that information from you later and share it, maybe.
Yeah, that's, yeah, I can get the exact links and stuff.
She said of the children eating.
Oh, of the children eating, yes. I'll get those exact links and we can share those with you. Is she talking about the end videos? Because those were my own clients.
Well, she mentioned YouTube, so it must have been one of the YouTube videos you shared.
Okay, yep.
Okay, yeah, we'll definitely share that with you guys. And from Eric again, does sealing the lips improve chewing as well as swallowing?
Well, sealing the lips makes intraoral pressure, right? But there's more to it than just, you know, there's so much more to it than just helping that. It's going to help the food not fall out of the mouth. However, it's not necessarily going to help somebody crush food better if they don't have the stability to do that. It is going to help with swallowing because, again, it's creating that intraoral pressure for swallowing. However, if they have tethered oral tissue, that's going to affect, even though their lips are closed, that's going to affect whether or not that food can be propelled down into the pharyngeal cavity. Again, you know, a pressure mechanism, right? So is it going to help them chew better? It's going to help with management of the food is what I would say. But there's so many other things involved in chewing as far as just being, you know, the stability of the mentalis, or not the mentalis, the masseter muscle to be able to crush the food, and the ability of the tongue to lateralize to keep the food on the side in a bolus, and then the tongue being able to retract and propel the food down in the pharyngeal cavity.
Thank you. And from Kristen, she says, I have a child who is 8 with moderate autism. He has the strength to chew. However, lately he has been choking due to a recent onset of only chewing the food 2 to 3 times per bite. He also recently developed seizures. That is the only catalyst. I have been working on chewing skills and reinforcing when he does chew adequately. He has some difficulty following directions. Any other recommendations to help him chew enough times without all of the cues that we are giving him?
Yeah, that's hard, right? Because you wonder if now, because of the seizures, is he having less awareness in his mouth? So you might look at doing some more like sensory awareness type activities with him in his mouth, such as like the toothed, or, even if you could get him to like tap with his fingers when he's chewing to kind of give himself a cue of how many times he needs to chew, maybe first showing him visually and then trying to reduce that visualization until it becomes, habitual motor plan. Those would be, those would be two of the things that I would think of.
Thank you. And from Sarah, can I use the chewing hierarchy on a 12-month-old? She currently only mashes food with minimal lateralization. She will be getting checked next week for TOTS. She demonstrates difficulty with biting as well. She coughs and chokes with solids currently.
Okay, so yeah, it sounds like you've definitely got some things going on there. It's going to be very interesting to see if she is choking on those solids because she has tethered oral tissue, or is she choking on them because she's swallowing them whole, Or is she choking on them because she has no, sensation, and then, it's going down the wrong way. So, yes, you can start that bite tube hierarchy with, or Lori Overland.
Uh-oh, Monica, can you hear me? We lost you there. You're frozen. Can you hear me? Okay, can you hear me? I can't hear you yet. Hi, I can't hear you. Sorry, everyone. Hopefully we can get this fixed in just a few seconds. Okay. So if you guys want to hang out, we'll try to get Monica back on. If not, we'll definitely share the answers with you guys. Okay, so yeah, we'll just, I'll send the remaining questions, or I'll send all the questions to Monica and have her answer them, and then we'll send it in an email for everybody to read. So I'm sorry about that we got kind of cut short there, but yeah, you should be receiving that email hopefully by Monday. So thank you all again for joining us, and hope to see you at the next Talk Tools webinar. Thank you. Bye.